Chapter 21, Eating Disorders, Part 2. So we're going to talk about nursing diagnosis. Refer to Table 21-2 in your textbook. So your nursing diagnosis include impaired nutrition, less than body requirement, related to refusal to eat, deficient volume, risk for or actual, related to decreased fluid intake, self-induced vomiting, laxative use, or diabetic or laxative abuse. Infective denial related to a delayed ego development and the fear of losing only aspects of life that he or she perceives some control over, which is eating. Imbalanced nutrition, more than body requirements, related to compulsive eating or compulsive overeating. Disturbed body image, low self-esteem related to retarded ego development, dysfunctional family system, or feelings of dissatisfaction with body appearances. Anxiety, moderate to severe, related to feelings of helplessness and lack of control over life events. Outcomes. So the patient has achieved to maintain at least 80% of expected body weight. Patient has vital signs, blood pressure and lab studies that are normal. The patient verbalizes the importance of adequate nutrition. Outcomes continued. So the patient verbalizes knowledge regarding consequences of fluid loss caused by self-induced vomiting, diuretic or laxative abuse, and the importance of adequate fluid intake. The patient verbalizes events that precipitate anxiety and demonstrate techniques for its reduction. Outcomes. The patient verbalizes ways he or she can gain more control over the environment, thereby reducing feelings of powerlessness. Patient expresses less preoccupation with their own appearance. The patient verbalizes the image of the body as fat was misperception and demonstrates the ability to take control of their life without resorting to maladaptive eating behaviors. The patient establishes a healthy pattern of eating for weight control and weight loss toward a desired goal and is progressing to that goal. The patient verbalizes plans for future maintenance of weight control. Some assessment findings that may necessitate hospitalization include malnutrition, which is 20 to 30% below expected body weight, dehydration. This assessment may include thirst, orthostatic hypotension, which is when your blood pressure drops when changing positions, usually from a lying to a sitting or sitting to a standing position, tachycardia, elevated sodium levels, and maybe some other symptoms. Severe electrolyte imbalance, including potassium levels below 3, phosphate levels below 3, magnesium levels below 1.4. Cardiac dysrhythmia. So ST segment and the T wave changes usually relate to electrolyte imbalances. Severe bradycardia. So heart rate is below 50 beats per minute. Hypothermia. Your body temperature is below 96.8 degrees Fahrenheit. Hypotension. A pattern of low blood pressure or orthostatic hypotension, which is when your blood pressure drops 20 millimeters of mercury or greater when you're changing positions. and your pulse rate increases 20 beats per minute or more, and suicide ideation. So these are all reasons why hospitalization may be necessary. Nutrition and deficit fluid volume. Imbalanced nutrition is less than body requirement as defined as intake of nutrients insufficient to meet metabolic needs. Deficient fluid volume is defined as decreased intravascular, interstitial, or intercellular fluid. The goal should include helping the client gain an established amount of weight per week and eliminate signs and symptoms of malnutrition or dehydration. Planning and implementation continued. So you have denial. Establish trusting relationships. Avoid arguing or bargaining with the client. Obesity. Encourage dietary of food intake. Provide instruction about the medications. Implementation continued. Disturbed body image, which is defined as confusion in the mental picture of one's physical self. Low self-esteem is defined as negative self-evaluating feelings about self or self-capabilities. So the client with anorexia nervosa or bulimia promotes feelings of control, help the client to realize the perfection is unrealistic. So these are some of the plans for this patient's recovery. For a client with BED, binge eating disorder, help identify positive attributes, refer to a support group or therapy group. Family education. So the nature of the illness. So you want to describe the symptoms of anorexia and bulimia nervosa. What constitutes obesity? So know your BMI ranges so that you can explain that to the families and they'll understand the healthy BMI. Causes of eating disorders. Effects of the illness or condition on the body. And please refer to box 21-4 in your text. Education continued. Management of the illness. So you want to teach your patients about proper nutrition, ways the client can feel that they are in control of their life, importance of expressing their feelings and fears rather than holding them inside, alternative coping strategies. Management of the illness continued. So your patient needs to be taught how to correctly administer prescribed medications, the indication for usage, the side effects of the medication, and relaxation techniques, as well as problem-solving skills. So education for the obese patients, so that's our patients that are binging but not purging, right? So we might have our BED, binge eating disorder patients. All right, so you want to educate them on nutritious meals, on how to reduce calories, on how to read labels, how to establish a realistic weight loss plan, as well as physical activity plan. So you want to educate your client and family on different supportive services out there, such as Weight Watchers International, Overeaters Anonymous, other national groups such as the Association of Anorexia Nervosa and Associated Disorders, or National Eating Disorders Association. Evaluation of the client with the eating disorder requires reassessment of the behaviors in which the client sought treatment. Behavioral changes will be required by the client and family. So for a client with anorexia nervosa or bulimia nervosa, the client, there are some questions listed to assess or evaluate the care plan. Your textbook has them listed. I'll read a few. So, has the client steadily gained 2 to 3 pounds per week to at least 80% of their expected body weight and size? For a client with binge eating disorder or associated with obesity, has the client shown a steady weight loss since starting the new eating plan? And if you recall, the binge eating disorder, they're not purging, so therefore they're gaining weight. For the client with anorexia, bulimia, or binge eating and associated obesity, one of the evaluation questions could be, has the client developed adaptive coping strategies to deal with stress without resorting to maladaptive eating behaviors? Treatment modalities, behavior modification. So issues of control are the central etiology or cause of these disorders. For a program to be successful, the client must perceive he or she is in control of their treatment. Success has been observed when clients are allowed to contract for privileges based on weight gain, have input into their care plan, and when they can clearly see what the treatment choices are. Staff and clients also agree on a system of rewards and privileges that can be earned by the client who is given the ultimate control. So he or she has the choice of whether or not to abide by the contract and a choice of whether or not to earn desired privileges. So some of the things that the client may have control over are listed here: eating, pursuit of exercise, whether inducing vomiting. So individual therapy may be helpful for underlying psychological problems that may contribute to this maladaptive behavior. But in general, psychotherapy is not the treatment of choice or therapy of choice for eating disorders, but it is the treatment of choice to treat any underlying mental illness. Family therapy involves educating the family about the disorder, assess the family's impact on maintaining the disorder, assist in methods to promote adaptive functioning by the client. Psychopharmacology. So no meds are specifically indicated for eating disorders. Various meds may have been prescribed for associated symptoms such as anxiety and depression. Medications that have been tried with some success for anorexia nervosa include Prozac, Anafranil, Periactin, Thorazine, Zyprexa. There are some medications to treat bulimia nervosa. So we have Prozac, Tofranil, Norpramide, Evel, Nortriptyline, and Nardil. And treatment for BED or binge eating disorder is Topamax or lisdexamfetamine.